Hi, this is Brian Kim. I'm going to share with you case number 235 in the Best Way to Do Cataract Surgery series. And the purpose of this title is not to suggest this is the best way, but to get you to think about your best way to do cataract surgery, which means scrutinizing your technique, looking at seeing what you can do better, refining, enhancing, and honing your technique so that you can do the very best for your patients. So this patient has a small pupil, a little bit of an IFIS pupil as well. You're going to see careful lens disassembly using double chop and cross chop. And again, utilizing the instruments to protect the iris and the pupil with the chopper in particular as I'm disassembling the lens. As you can see, this is the left eye. There's a little bit of a Bell's reflex. I'm using the cotton tip to steady the eye and then using a corneal marker, which will help me to center and size the rexus. I'm trying to turn the eye again down. This patient's resisting me a little bit. I'm using my paracentesis incision first on the right side and then the left side, making sure I'm parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and to viscodilate the pupil as well. I'm using the Orlock technique, twisting the cannula within the incision to be able to turn the eye downward. And this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove tunnel, and then when I'm ready to enter, I turn the eye towards me and I enter. You can see this patient's really resisting, trying to look up, but I'm using that twisting maneuver of the cannula at the incision with the Orlock technique. You can see the cannula slipped out, and again, that's because this patient has such a strong Bell's reflex, but that's okay. Even though it slipped out, I go ahead and back in, and then I'm going around circumferentially with the microforceps. I punctured the center and went down, and I'm going around circumferentially. Once I get to the left side of the rexus, I don't really need that cannula because I'm turning the eye towards the left to finish off that rexus anyways. Burping some viscoelastic out of the incision and then coating the cornea with the viscoelastic. Irrigating the surface very gently. And this is the capsule fornix hydrodissection technique. I place the cannula under the rexus edge contra-incisionally, point the tip down, get a nice wave, lift the lens up, tilting it, decompressing the bag, pushing the lens back down into the bag, sweeping under the rexus edge with the BSS cannula, and then rotating the lens on the right side, and the lens begins to spin. Adjusting my sleeve, lifting the incision with chopper, going in with irrigation off to minimize Descemet's trauma, removing all the surface epinuclear material. So again, the pupil is really not that bad at this point, but you'll see down the road as the case progresses. You see I'm pronating my hand. I'm leading with the chopper tip. I'm fairly flat to the lens surface. I'm going to slide the chopper under the rexus edge, leading with the tip. Once I get to the lens equator, I rotate the chopper vertically, and now I'm at the same horizontal plane as the densest part of the lens. I'm turning the phaco tip vertically subincisionally. I'm getting around the lens and pushing it into the softer epinuclear material. I'm bringing both instruments together, and I'm crushed the lens completely in half by bringing the instruments towards the center. Go ahead and do some separation here. I didn't feel like there was a through and through chop, so I went back and did another double chop maneuver. And the point is, you can always go back and do another chop maneuver with mechanical fracturing techniques. So this is the third time I went back again, and now I got a full fracture. So I go ahead and pronate my left hand again, making sure that chopper is flat, sliding and leading with the tip, sliding it under the right heminucleus. I'm going to slide it under the rexus edge, under the right heminucleus, and then I'm going to rotate it vertically once I'm at the lens equator, pulling it centrally toward the phaco tip and fracturing the lens against the phaco tip, and that is the cross chop. Look here, as I'm grabbing that first quadrant with high vacuum, I'm positioning that chopper in such a way that I'm shielding the iris and pupil away from my phacotip. If I'm not careful, my phacotip might grab that iris, so I made sure I shielded the iris as I'm doing that maneuver, rotating the lens to loosen up that second quadrant, separating it using the instruments. The lens is a little bit sticky and it won't come out, so I get around the lens one more time with the chopper and lift that piece up and then emulsify the lens piece. I'm rotating the second heminucleus in front of me. Placing the chopper around the lens, hooking the peripheral lens, fracturing the lens against the phacotip. Again, using some vacuum to pull the piece up, but you saw I use the chopper to kind of shield the pupillary edge from the phacotip. You can see that the pupil is trying to come down, which means that I did have very good viscodilation, but as I'm trying to eat up those pieces, unfortunately, I am getting viscoelastic removal as I'm eating those pieces because I'm right within the pupillary center. And because the pupil is so small, I can't help but eating the viscoelastic around the pupil, and therefore the pupil has come down. So again, I'm very careful as I'm eating the lens pieces. All the endonucleus has been removed. Again, I'm trying to protect the pupillary edge as I'm grabbing the epinucleus now. And as the epinucleus comes up, I make sure that the phacotip is right in the middle so I don't eat the iris and definitely don't eat the posterior capsule. So I take the chopper out, push BSS in, take the phacotip out, and I make sure I deactivate infusion as I come out because I don't want the iris to come out of the wound. I start subincisionally with the INA handpiece, peeling from anterior to posterior. And even though this is a blind maneuver, I'm very carefully going under the rexus edge, looking for that cortex. I switch to polish mode now, which gives me some extra protection. Since that pupil's come down, I have to be very mindful about my aspiration and vacuum. Because I cannot see the rexus edge, I just go ahead with the cohesive viscoelastic now, and I do not do the pulsing of the BSS. If I can't see the rexus edge, I really don't want to pulse with that BSS, because if you just pulse into the sulcus, and you're just going to cause pigment liberation from the iris, and it's really just not necessary. It's not something you want to do. Doing a little bit of polishing with the sweeper. As I go in with the injector for the Li61AO lens, I push some more viscoelastic to fill the bag. You see the leading haptic came out rather abruptly, but again, everything was in good position. You have to trust that the leading haptic is going to go into the bag once you have it down at that level. And even though it does swing around, as the optic comes out flat, the haptic kind of rewrites itself. And then you saw I was able to withdraw the plunger and push it again, and I was able to place the trailing haptic within the bag. I have the Maltzman there to check to make sure both haptics are within the bag, which they are. I get underneath the lens with the INA handpiece, removing all the viscoelastic from within the bag, using that Maltzman to help me again. You see how small this pupil has become. Clearly, this is an IFIS pupil. I go ahead and switch to polish mode, polishing under the rexus edge, removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, look how small the pupil is. Look at the IFIS. This patient clearly had a pupil that could have caused a lot of problems, but I started off with good viscodilation, and then I leveraged mechanical fracturing to crush the lens into smaller pieces. By using mechanical fracturing, that means I'm using less vacuum. And if I use less vacuum and I focus on mechanical fracturing, I can efficiently disassemble the lens without using vacuum. Therefore, I'm not removing as much viscoelastic as I'm disassembling the lens. Now, of course, I am going to remove some viscoelastic as I'm trying to emulsify the lens pieces and take them out of the eye. I can't help that. But if I use a lot of unnecessary vacuum, what would happen is the pupil would have come down a lot earlier in the case while I had a lot of lens material in the eye still, and it could have been more challenging. You saw how I used a chopper to shield the pupil from the phacotip, and I shielded the pupil from high vacuum. And so, again, utilizing the chopper to protect and shield the pupil from the phacotip is another benefit of doing cataract surgery this way. Again, utilizing mechanical fracturing also reduces vacuum, therefore reduces OVD removal throughout the case, which again preserves that bigger pupil and pupillary dilation from the viscoelastic. And so this is why I feel like this is the best way to do cataract surgery, especially in a small pupil, not just a small pupil case, but also for an IFIS case. So I hope this was helpful to you, and I thank you for your attention.